So today we're going to talk about aortic catastrophes. And I must say that throughout my career, I've been sort of a shit madman for these. My very first case, on my very first day in the emergency department, so my very first day as an emergency physician, right? I was in there, and I was like this, and the chief resident, Joe Shin, I'll never forget his name, he says, why don't you go, he didn't know me, right? I was just a fifth going, he's like, why don't you go see that guy with atypical chest pain? So I went over to see the guy with atypical chest pain, and he was a very nice man who had the sudden onset of very severe interscapular pain while engaged in the physical act of love. So he stopped what he was doing and came to the emergency department, which is like a warning sign, right? If you stop doing that so that you can come to the emergency department, something bad is going on in your life. So I come, but I wasn't like together enough to realize that it was just atypical chest pain after all. And so I'm talking to the guy, I'm taking his history. I'm at his bedside maybe 5 minutes, taking the history of the guy. That's pretty much the information I'd gotten out of him. I knew his blood pressure was a little high, and Larry Schwartz comes to the bedside, and is this too much like personal information? He comes to the bedside, and he's like, so, Dr. Sullivan, first day. Oh. And I'm like, yeah. He's like, so what do we have here? And I didn't know what I was doing, but I wanted to sound like I knew what I was talking about, so I just parroted what the chief resident said. Well, we have a patient here with atypical chest pain. And so Larry starts talking to the guy, and we're talking to the guy, and he's like I say, he's a very nice man. And Larry says, you have this sort of like funny rash on your face. And the guy's like, yeah, it's been there since I was at, and he stops in mid-sentence, rolls his eyes up in his head, and dies. Like, right there. Dead, mid-sentence. Gone, right? And I will never forget my first day as an emergency physician, first patient, looking across the bed at Larry Schwartz going, so this is our patient with atypical chest pain. Dr. Sullivan? So that was the start of my career. And I've attracted a number of these cases ever since. So I have a special place in my heart for aortic catastrophes. So let's talk about them. We're going to do this in two parts. We're going to talk about AAAs first, and then we'll talk about the sections. But in general, they don't call them catastrophes for nothing. These are bad cases. They kill a lot of people every year. They are diagnostic and therapeutic challenges and have been ever since they were first recognized. They remain so to this day. These are highly time-sensitive processes, which if you don't make the diagnosis early, you're going to find yourself in the lead and the patient may be unrecoverable. They may be unrecoverable even if you do make the diagnosis early, but if there's a delay in diagnosis, they clearly have a higher mortality. Let's start by talking about aortic aneurysm. You can see that this is just a monster, right? And it's going to get, these are bad players. They seem to be increasing in incidence. The size of diagnosis seems to be increasing. This is probably not an artifact of our increased ability to diagnose it because we're so much better. So it probably has to do with the fact that the patient population is getting older, and there's a higher burden of arteriosclerotic and peripheral vascular disease. The fact that the size of diagnosis is increasing should be concerning to all of us because mortality and rate of rupture are both directly affected by the size of the aneurysm. Up to 10% of our patients over a certain age may be affected by one of these monsters. As you know, men are affected more often than women. Sorry, guys. And most patients who have one of these creatures growing inside them are not diagnosed until the bad thing happens. Right? That should also frighten you. The remainder are usual incidental diagnoses. That should also frighten you. In other words, you didn't find it because you were smart enough to go looking for it. You found it, you stumbled over it because you were looking for something else. So none of this is good news. Most of this you know. Again, 10% over 65 may harbor it. Y chromosome is a risk factor. Sorry, guys. If patients have cardiovascular disease, peripheral vascular disease, arteriosclerosis, they're at increased risk since that appears to be part of the underlying mechanism. There is some demographic or epidemiological evidence that patients who are on calcium channel blockers long-term have an increased rate of the development of aortic aneurysm. And this is presumed to be due to the increased arterial stiffness. That is a completely unproven hypothesis. In plain fact, nobody knows why patients on calcium channel blockers seem to be slightly predisposed to the development of aortic aneurysm.
So people should stop taking their blood pressure medicine?
Always. And they shouldn't take their diabetic medications either. They should just use crack and alcohol. There are some genetic factors that have been identified. Patients who are, inflammatory type patients, patients with certain types of collagen vascular disease, obviously. And there have been some susceptibility loci located on these chromosomal arms here. As far as I know, nobody has actually identified the proteins or the mechanisms that lead from these genotypes to the development of AAA, but I'm sure somebody's working on it somewhere with your tax dollars. Here's the problem. Misdiagnosis is extremely common. It's almost the standard of care to miss the diagnosis, especially unruptured AAA. The most common misdiagnoses for AAA are renal colic, it's just a stone, diverticulosis, right? Yeah, he's an old guy, he's got diverticulosis. UTI, back pain, maybe a little hematuria, you can see how these things would go. Spinal disease, lumbar strain, right? When you make one of these diagnoses, you need to stop. And you, like most times in the year, you need to stop. You remember to be afraid, you need to remember to think, and you need to consider imaging. So when you've got an old guy that you're about to send home with pyelonephritis on the basis of lumbar pain and some blood in his urine, you need to stop. You got an old guy who complains of the sudden onset of back pain, and you're about to send him home with a lumbar strain, you need to stop and think. And patients in the right demographic, you need to stop and think. Because how long does it take to image? Because unlike when I was in your position, today, imaging is quick and easy. What am I talking about? How long does it take to put some jelly on the belly and put an ultrasound on them and measure the size of their aorta and sleep better at night? Not long at all. So, these are the most common misdiagnoses. When these diagnoses go through your head or when you're typing them out on Logicare, you need to stop and think. Remember to be afraid. Diagnosis is frequently delayed until shock sets in. And by then, you and your patient are seriously in the weeds, right? Mortality jumps up like exponentially. Once you start to recognize that this really isn't a lumbar strain after all, your mortality has already increased to the point where the patient will often be unrecoverable. I think we're probably all pretty well scared enough by now, but look at this. Rupture has a mortality of 80 to 90%. Even if you make the diagnosis and get the patient to the OR before he succumbs, he still has an extremely high mortality. From half to 70% of those patients are going to die. And 9,000 deaths a year in the United States, probably more than that. Here's a great CAT scan, right? A CAT scan that you don't want to see. You don't have to be a rocket scientist to figure out what this is. It probably would have showed up on a plane film, right? And this is badness right here. So this is leak from a ruptured AAA. This is a patient who's probably not going to do well, right? Not least because you stop to get a CT, right? This guy belongs in the OR, not in the CAT scan. So this is a person who's probably not going to do well. Talk about a little bit about the pathophysiology and the morphology of these. There's actually the possibility that they can dilate, as they say, from nave to chop. These type 2s, look at this monster right here. Pretty incredible. The kind that we see most often, these thoraco-abdominal aortic aneurysms and thoracic aneurysms, they're a little less common than the classic AAA, either infrarenal or suprarenal. These kinds are a little bit more rare, but you can see how they would just be catastrophic. It might confound the clinical picture a little bit. Who said this? Name the child. Anybody? What?
Osborne.
That's from Macbeth. Name the child.
Sally.
You know, it's always a good bet when somebody asks you who said this, to either say the Bible or Shakespeare, right? You're going to be right like 80% of the time, so you can at least throw something out there. Here's the classification scheme, AAA classification. One is the infrarenal with or without extension of the iliacs. Class 2 are the juxtarenal, which start to get a little bit trickier in terms of surgical repair. Type 3 are a surgeon's nightmare because they're pararenal. They extend up a little bit past the renal arteries, and these are just a mess, right? We don't really have to be concerned with differentiating between these. Just know that there is a classification scheme, and that the higher you go in the class of AAA you have, the more of a nightmare it's going to be for your surgeon when he gets in there to actually conduct repair. You can see how a repair of this is going to represent certain technical challenges, whereas this is going to be a little bit more simple. Our job is basically to just make a diagnosis. Recall that there are true aneurysms and pseudoaneurysms, and the difference between them is that a true aneurysm involves all the layers of the vessel wall, right? All 3 layers of the vessel wall, and this is usually due to some sort of biomechanical or inflammatory degeneration. Most are degenerative due to breakdown of elastin and collagen in the media. There is some evidence that infectious agents can lead to degeneration in media, but as I say here, there's some evidence that Loch Ness Monster and Bigfoot too, this epidemiological evidence is a little bit questionable. And there's no evidence that treating patients empirically for CMV and chlamydia is going to decrease the rate of increasing size of the aneurysm. There's a clear association between arteriosclerosis and the development of AAA, but the mechanism is actually not so clear. I mean, what you see when you look at the literature is people waving their hands about biomechanical degeneration and the distribution of forces on the inside of the AAA, and that's all. I mean, I don't think anybody knows exactly how it happens. And again, there's no clear genetic defect or mechanism that's been identified. So gene loci have been implicated, but there's no clear, proteomic analysis, no indication of how those genes actually affect the phenotype of AAA. Yeah?
The association with chlamydia and infectious agents is interesting. It's this same kind of thing you'll get with some of the collagen vasculature. People will end up getting Reiter syndrome. Look at these people and they'll have different genetic variation as compared to everyone else. So whether that's related to this as well and it's part of a greater thing in terms of connective tissue.
Yeah, and well, a little bit off topic, but this is a problem that we run into in biomedical research a fair amount. It's pretty easy with new genetic and statistical methods to show that a particular gene polymorphism, particular genotype, will sort with a particular phenotype. I mean, you can show that. Finding out why that is, and whether it's an actual cause-effect kind of thing, and what the underlying mechanism is, or whether it's just some sort of phenomenological association, that becomes a lot more difficult. Because then you actually have to identify the proteins and how the proteins work and how they actually lead to the development of a disease state or a particular phenotype. That's a lot harder. So there's lots of genetic associations that have been identified in medicine. Mechanisms, they take a little bit longer. True aneurysms can expand at a rate of about 0.5 centimeter a year. So do the math. We're usually concerned about aneurysms at about 3.5 to 4 centimeters in diameter and beyond. And we know that the risk of rupture increases as the diameter of the aneurysm increases. And what's more, as the aneurysm gets larger, its rate of increase tends to increase as well. So really, if you're walking around with a 2.5 or 3 centimeter aneurysm, your days are literally numbered. I mean, just do the math, realize that the aneurysm is growing and that it's going to grow faster as it gets bigger, kind of like the universe. It's going to be faster and faster and faster. We'll talk about that a little bit more later. And so the risk of rupture increases exponentially. So even making the diagnosis of the small unruptured aneurysm is going to be clinically important for that patient, right? And then there are false aneurysms. False aneurysms involve an abnormal collection of blood that has, in a sense, it's a little bit like a dissection that's found its way through the intimal and medial layers, either due to degeneration, trauma, the creation of an intimal flap, like perhaps by a deceleration injury. And these are contained only by the adventitia or soft tissue. Their rate of rupture is relatively high, but not as clearly defined or steady. So it could rupture today, or a year from now, or while you're on your potty break and asking the patient or the nurse to put the patient on a monitor, right? So it could rupture at any time. There's no way of predicting when one of these kinds of false aneurysms is going to rupture. So that's the right. So let's talk about clinical presentations. First, we'll talk about unruptured AAA. Might as well get it out of the way because most of the time you're not going to make this diagnosis, right? It's just unfortunate, but it's usually an incidental finding. There's no clear pathognomonic presentation that's going to, aside from the large pulsatile abdominal mass, which you are never going to see, right? So it's a tough diagnosis to make. Very few patients come in and say, yeah, I think I might have an unruptured AAA, right? Or have a presentation that clearly indicates that. The symptoms are completely nonspecific. Abdominal, fat, flank pain. How often do we see that? And abdominal fullness. All our patients have that, right? You could hide a sheep in most of our patients and you'd never be able to hide it, right? You may be lucky. They may actually present with a presentation that may sort of indirectly put you on the path of a AAA. They may present with something like an embolic presentation, acute arterial insufficiency. Patient's got a cold leg, evidence of mesenteric ischemia, renal infarction, something like that. The compressive presentations that we all learned about in medical school, at least that I learned about in medical school, so that you had the AAA there, and it was going to erode into some other structure. Its chronic presence was going to cause, the spine to be eroded away, or it was going to erode its way into the gastrointestinal tract, or something like that. That's actually not very common, and you can't rely on that. It happens, but it's actually very uncommon. The bottom line is that you always have to consider AAA in any patient in the appropriate age group who presents with any sort of vague radical abdominal complaint. And that's a tall order, but you always have to think about, because we see 1 million of these a day. So it should always be in your differential. Again, it only takes a couple of minutes to put some jelly on the belly and give a look. Right? It should just become part of your standard thinking about this population of patients presenting with these kinds of general complaints. Ruptured AAA is not so subtle, usually, right? It's actually usually a lethal event. I mean, think about it. Pop your aorta. Unless you have some tissue there or a tamponading structure, right, or some sort of limitation on the rate of hemorrhage, you're just going to die right away, right? It's this. I mean, really, what do you do about that, right? So what we're really concerned with in this presentation is the patients who don't have the good sense to just die immediately, right? They don't have the common courtesy to just flatline right away, right? Those are the patients that are going to give you trouble. We know that there's the classic triad: hypertension, pain, abdominal mass. So when you see that, you know, I've got a ruptured AAA here. Why didn't this patient just die at home, right? because now I've got a problem. Unfortunately, this triad, like most classic triads, what was I heard recently? Somebody, I think it was on like EM-RAP or something, somebody said, classic triad is Latin for 15% of the time. Right? I can't remember who said it, but damn, it sure is true, right? It's almost never present. Shock, on the other hand, is usually present, right? You're usually going to see it, but it may not be present. The patient may have tamponade of the aneurysm and may not actually be hypotensive or hypoperfused. And sometimes patients will present as a massive GI bleed, where you are probably not going to think of this right away, and where you're probably going to miss the fact that the patient's got a AAA that's ruptured into the gastrointestinal tract, and they're almost certainly going to die. Even if you do make the diagnosis, the mortality is extremely high. But the fact is that a lot of times the diagnosis gets missed, especially in patients who present like this, and then the mortality is even higher. There is a presentation called the aortocable fistula syndrome. It's characterized by high output failure in a left to right shunt. What's happened here is the aorta it's one of those rare erosive syndromes where the aorta, proximate to the inferior vena cava, has actually eroded into the inferior vena cava and has formed a fistula. There's a fistula that's chronically formed between the two, or is formed at the time of rupture. And now, blood under high pressure, right, on the left side of the cardiovascular system is being forced on the right side of the cardiovascular system, right? So instead of going all the way down to the capillaries and coming back, it's just going through the IVC and back up, right? So it's a huge left to right shunt. They'll have a continuous abdominal bruit. You guys know what an abdominal bruit is? That's like where you put your stethoscope on the patient, which you never do, right? Put the stethoscope on the patient's abdomen. When was the last time anybody did that? You put your stethoscope on the patient's abdomen and listen for a bruit. Who does that? Don't lie.
Do you do it for bowel sounds, or do you do it checking for a bruit?
Yeah. I don't do it looking for bowel sounds. Yeah, bowel sounds are kind of useless. What about bowel sounds in all four quadrants?
Yeah.
4 times
Or you
is
gotta do
useless.
one quadrant.
Right. Yeah. If you don't figure it out, that the patient's got, because this is not a free rupture, right? The patient doesn't have a free rupture. They're not bleeding to death inside their abdominal cavity, right? They're bleeding from their aorta into their inferior vena cava, and they present as a left to right shunt with a loud abdominal bruit. If you don't figure it out, they're going to die. And maybe if you do figure it out, they're going to die, right? So it's a confounding presentation. Here's the anatomy. You can see that down here in the abdomen, here in the area where you're most likely to form a AAA, the IVC runs very, very close to the aorta, and you can erode into that space, or you can erode into that structure and form a fistula at the moment of rupture. Here's an actual enhanced CT image of it, right? So look at the monster here. This is a huge AAA, and you can see that it's ruptured into the inferior vena cava. In contrast, it's flowing from the aorta into the IVC. Right? It's bad news. Syncope may be the only presented complaint, and this underscores a simple truth that syncope in an old person is bad news until proven otherwise. Right? I always think about, I actually have a slide that I'm going to show those guys at GM this morning about syncope, because I'm going to want to keep it really simple for them, right? So syncope, one's a picture of Marge Simpson, you know, she's a young lady, like 30 years old. One's a picture of Grandpa Simpson, right? That's what you have to keep in mind. In Marge, the clinical course is excellent, right? In Grandpa Homer, not so much, right? That's how I think about syncope. Young people who don't have any evidence of brugada or don't have a ruptured ectopic or something like that, syncope has a benign clinical course. Once people get to be past, my age, the clinical course is not so good, right? So old people with syncope have to be worried about it, and AAA definitely belongs in the differential for those people. So you can have a person who had and and they passed out, and now they're fine. Feel good. Belly feels a little full, but other than that, I'm good, doc. Ready to go home. They have a ruptured AAA. Right, that they're just stamping out at the moment. So you need to keep that in mind. Physical findings. Your exam sucks at picking up AAA. Right? And this is probably not your fault. The literature is very clear on this topic. Our physical examination has a low sensitivity and specificity, well, low sensitivity anyway, for AAA. Specificity of a pulsatile abdominal mass in a prostate patient is pretty good, right? Wow, this patient's in shock, he's white as a sheet, and he's got a pulsatile abdominal mass. That's not a sensitive finding because it's usually not present. But when you find it, it's pretty specific, right? You know that you've got a AAA. Look at this. Sensitivity as low as 33%. What do we call a test that has a sensitivity of 33%? That's not so good. Specificity, again, right? You won't feel that throbbing mass very often, Frank, but when you do, you'll know it, and you'll know what it is. The bigger the AAA, the easier to find, right? Especially in lean patients, young, relatively younger, lean patients where you can palpate the structure, and not our patients. Right? Obesity decreases the sensitivity of the exam. Unfortunately, patient obesity and AAA often go together. The affection physician obesity is here. Pulse deficits and bruits. Everyone talks about these. I remember somebody telling me, did you listen for flank bruits? Listen to the costovertebral angle of flank bruits. No, I didn't do that. I got an ultrasound for crying out loud, right? Very, very, very insensitive and non-specific. The take-home message here is, again, your exam sucks at picking up AAA, and you cannot rely on an exam, just like you couldn't rely on historical features to rule the diagnosis in or especially out. So just because your exam is negative, so here's what I see. Guy's got an old guy with abdominal and flank pain. He comes in, and somebody tells me that his femoral pulses are good. Femoral pulses are good. We're all good. He's got bilateral femoral pulses. We can all relax, right? Do not make that mistake, right? There are no exam findings that rule this lesion out. We'll still say that. They hated, so we're going to talk about imaging, diagnostics now. They hated hated abdominal film. It's actually not completely useless, right? If you are concerned about AAA, this is not the test to get, right? Better to just put the ultrasound on the patient. It's faster, the patient doesn't have to leave the department, it's going to be more sensitive and more specific than the abdominal film. However, if you get an abdominal film for another reason, say to rule out obstruction or perforation, which are just about the only reasons left to get an abdominal film, and you see one of these things, calcification of an aortic monster, loss or displacement of the renal shadows, or obscuration of the psoas shadow, then you could be alerted to the diagnosis and make the incidental finding of AAA. And I don't know if you all can see this or not. The arrow helps, right? You see this eggshell calcification way out here lateral to the lumbar spine, indicating, and you can see it over here too. So here's your aorta, right? From here to here. So this guy's walking here. Somebody probably got it to make sure his artificial hip was okay or something like that, right? Look for a kidney stone. Who knows why they got this film? And then they, whoa, what do we have here, right? And this should be part of your regular approach to looking at abdominal film, looking for any signs of a AAA. And, there we go. I probably look a lot better on the camera that way. Ultrasound. So this is the first line imaging modality for your approach to the patient with suspected AAA. Right? It's rapid, it's non-invasive. ER docs can do it. Younger docs, especially, can do it really well. You don't have to move the patient out of the emergency department. You can be doing other things Nursing can be doing other things while you're doing the examination, waiting for surgery to come, so on and so forth. The sensitivity approaches 100% in some studies. I'm not so sure about that, but clearly the sensitivity is very high. The specificity is clearly very high. And if you have a patient who's got hemodynamic instability and evidence of a AAA on ultrasound, your job is done, and the surgeon's is just beginning, right? Unstable patient, AAA on ultrasound, you're done. That patient needs to go to the OR. Do not pass go, do not collect $200. So, as Billy Mallon says, in that situation, the ultrasound decreases the coefficient of friction between the emergency department and the operating suite, right? Allowing the patient to be moved like a watermelon seed between the fingers, right? You just shoot that patient to the OR, right? And this means with or without free fluid. This is actually a very important point that I want to hammer home a little bit. Ultrasound is sensitive to the presence of AAA. It is not so sensitive to the presence of rupture. So it only shows you that if you see rupture, that's great. If you see, it's actually not great, but if you see free fluid, right, then it's there. But just because the ultrasound does not show free fluid and does not show rupture does not mean rupture is not there. If you have a patient with pain or instability and a AAA on ultrasound, that patient needs to go to the OR. Most of you know how to do this. Even most of us old parts know how to do it now. If you don't know how to do it or you're uncomfortable with it, make sure, because this is even more important than fast, I think. Being able to do this examination. It'll save lives if you know how to do this examination and do it really well. CT is a good study. It's better for delineating the anatomy, for identifying the presence of hemorrhage or rupture, has a very high sensitivity and specificity. It may not be so good at detecting very small leaks. It may suggest alternative pathology, like, say, a stone or diverticulosis, something like that. And it may detect AAA as an alternative finding. The problem, of course, is that it's a CT, right? And it means that the patient has to leave the module and go to the CT suite, where, as we all know, our ability to perform resuscitation. Here's a CAT scan showing excellent resolution of a large abdominal aortic aneurysm, and look what we have here, right? And you can see how you might identify this AAA on ultrasound. You would identify this AAA on ultrasound, but you might not identify that, right? You might not see that. That's leak, right? So this patient's leaking from this AAA. Again, here's a patient who just needed to go to the OR. If this patient presented to the emergency department and you did an ultrasound and you saw this and they had hypotension or severe pain, you should have never got this CT. This patient should have just gone to the OR. Look at this. The word monster just keeps coming to mind. You notice that this patient has one of these thoracoabdominal aneurysm syndromes here. Look at this. This guy's got a problem. And this is CT. This is not MRI. This is reconstructed CT. So, excellent anatomical delineation. MRI, yeah, the magnetic chamber of doom. Suitable for patients who are stable, in whom the suspicion of a leak is extremely low. And as I say here, you're damn well better be right. Because if you think running a code in the CT suite is a bummer, try it in MRI someday, right? Excellent anatomical definition. The surgeons love it. And it is absolutely contraindicated in any patient for whom you have any suspicion whatsoever of rupture. This is not a test that you should be using in any patients who suspect AAA. Let the surgeon order. So, management of AAA is really simple once you've identified it or suspected it. It's really, really very, very simple. You can divide it into the management. non-ruptured AAA, and ruptured AAA. So the first question you have to ask yourself in the management of non-ruptured AAA is, how do you know? Right? You don't know on the basis of an ultrasound, right? Ultrasound and CT are both insensitive to leaks or small ruptures. If the patient presents with any symptoms of malperfusion, hypotension, right, pain, we in the emergency department assume that a rupture has occurred or is imminent and get surgery involved. Easy, right? Just think the way an emergency physician thinks. Oh yeah, he's ruptured. He's ruptured, right? That should be your first thought. He's ruptured until proven otherwise. If the AAA is an incidental finding and the patient who presented with, completely unrelated complaint, you got a CAT scan, you got an ultrasound, and you made an incidental finding of AAA, first ask yourself whether it's really an incidental finding, right? The patient presented with signs and symptoms of renal colic, and he's got a stone on CAT scan, and also a 4-centimeter AAA. Ask yourself, which one of those entities is really causing the patient's discomfort today? Make sure it really is an incidental finding. And the patient is stable, you're still going to ask surgery to come see the patient immediately, even if rupture is not suspected. In both cases, you're going to type and screen 10 units of PRVCs. You're going to put the patient on every monitor known to man. You're going to watch him really closely, and you're going to work closely with our surgical colleagues to image the patient and work them up and get them admitted. This physician is in coordinated surgery, and fortunately, I've never seen surgery sent home a new AAA. I just don't see that here. So other places it might be more problematic, but here we're lucky we have a pretty aggressive. Ruptured, again, easy, or I should say simple. It's not easy, but it's simple, right? Your duty is clear, right? So taking a few minutes to make sure that you don't soil your shorts, call the surgeons, type across 10 units of PRVCs, and get the patient ready to go to the OR. Right? Do not pass go, do not collect $200. Clinical suspicion of a ruptured AAA alone is sufficient to mandate a trip to the OR. And even if you're wrong, even if it's not a ruptured AAA, it's going to be something. Right? The data actually, the literature actually bears that out. Patients who go to the OR with suspicion of ruptured AAA either have a AAA or something else really bad, and they needed to be in the OR. That's what the literature tells us. This paper by Valentine et al. In 1993. AAA plus, we're going to hammer this home again, AAA plus an ultrasound, on ultrasound plus instability is ruptured until proven otherwise. Instability, malperfusion, pain, plus a AAA on ultrasound is ruptured until proven otherwise. Right? Because, again, ultrasound is not sensitive to the presence of a leaky AAA. So this really starts to all become very simple. Right? It's all about assuming that the patient has ruptured and getting into the OR. Once again, you're going to type across. These patients will just eat up blood. Type across at least 10 units of PRVCs and ask surgery if they want more. What about resuscitating a high? Yes?
Can I ask a question? Just a kind of logistical one.
What?
It's a logistical question.
Yeah.
Will they do these here or do they have to go to Harvard?
Ooh. The last couple I've had, they were both with the same surgeon. They were both diagnosed on ultrasound, and they both went to the OR here at Racine.
Okay.
Yeah, why? Yeah. God, I hope they don't have to go to Harvard. That would
If
be.
they're ruptured, they go here.
Yeah, they got
Just
it.
elective repair.
Yeah.
Okay.
Right.
All right. Because I was just going to say, like, when they go over to Harper, our type and screens are no longer valid. They have to get a repeat draw there. So don't pull 10 units of blood here if they're going to go.
But if you type and cross them for 10 units and you get our blood to get it ready, staff the surgeon will pick it up on their way to Harvard.
And take it with them.
They will take it with them. They do that the
Yeah,
other
you
day.
don't wait for anything. That's what this slide is about, right? This whole idea of resuscitation. So it's like, well, let's put in some lines, let's get a screening chest x-ray to make sure he doesn't have something in his chest too, and let's get the EKG to make sure he doesn't have, and I've got this awesome scan that I need to print out for Glenn, or abscess. Let's get that, right? Don't. The patient just got to go to the OR, right? Time is mortality. But this whole issue of volume resuscitation, so here's the deal, right? You take a pig and you ketamine the pig, right? And you do this aortotomy kind of thing. You do this it's like wire aortotomy kind of thing. And then you basically put a little wire in the aorta. And then when you're ready, right, you yank it out and you make this aortotomy, and now the pig is bleeding. That's your AAA model. That's your swine AAA model. And then you do experiments, right, like scientists will do, and you look at whether or not you want to use aggressive volume resuscitation. And it is pretty clear that aggressive volume resuscitation to normal tension in the setting of an aortotomy can be bad news if you're a pig.
Yeah.
There's pretty clear evidence of that. Large prospective randomized human trials have not shown that because there haven't freaking been any, right? How do you do a trial like that for ruptured AAA? Really, how do you do it? There will never be such a trial, right? So it's all a little bit academic. Most authors recommend maintaining SVP at around 90 millimeters of mercury. But here's my point, right? Who cares? You're not going to try and maintain the patient's blood pressure at anything. Your job is to get him to the OR, right? So a target blood pressure doesn't mean anything. Yeah, you're going to, between now and the time that you actually roll it, if you can, you're going to put in a line, you're going to type across the patient, but your real resuscitative intervention, the real procedure that is going to resuscitate that patient is this one, right? Rolling the patient to the OR. That is the resuscitative procedure of choice, not a target blood pressure or anything else. Trendelenburg, I don't care what it is, right? The only procedure that's going to save the patient is getting the patient to the OR after you, the most excellent ED physician, have made the diagnosis. Nothing we do in the ED will impact the patient's survival in any meaningful way except for that. Yes, ma'am.
So the other thing is you can call the secretary of surgery resident, but you should be calling the attending at the same time. This is not something.
Vascular or general surgery?
General surgery. If they're ruptured, you call general surgery.
My approach is, and I'll see what you guys, Eric, Scott, can have to say about this. My approach has always been, I turn to the residents like, you call the surgery resident, and then I call Ledgerwood or Larry, right, or Wilson. I call the attendant and say, I have a patient who needs to be in the OR 5 minutes ago because she's got a ruptured AAA. And that usually tends to work pretty well. Things tend to happen pretty quick. And last 2 or 3 of these cases I've had, it's been really easy. I have a patient I think needs to be in the OR, he's got a ruptured AAA. Okay, send him on over, and then you're done. Easy, right? Thank God I was right. Okay, so we're right on track. Does anybody want to take a break or stand up and stretch or anything like that? Because we've got about another hour. Speak and be heard. Why don't we take 3 minutes? All right?